Okay, welcome everybody. I'm here to introduce today's Grand Round speaker in Dr. K's absence. And I should start by reminding everybody and acknowledging the contribution of the Sidhani Foundation, which has kindly supported our ID Grand Rounds efforts. And we really appreciate Mr. Sidhani's ongoing support of education and innovation within our division and within this medical school. So let me introduce Dr. Rupak Datta, who is an MD PhD faculty member at Yale, who trained at Tufts in my old stomping grounds. As an undergraduate, did an MPH in epidemiology of microbial diseases at Yale, and then an MD PhD in epidemiology at UC Irvine. So he is focused on stewardship, has done a lot of work on stewardship in alternate settings, including outpatient settings and at the VA. And his topic today is talking about issues with stewardship in end-of-life care. So welcome, Dr. Datta, and I'll be quiet now.
Thank you so much, Dr. Borikoff. I really appreciate the introduction and this opportunity to speak with you today. It's a real privilege. So let me, allow me to, I guess, share my screen. Let me pull it up here. Okay. All right. And Dr. Borikoff, are you able to see my screen?
Yes, we are.
Very good. Very good. So thank you. So again, I really appreciate this opportunity. So the topic of today's Grand Rounds will be antibiotic stewardship during end-of-life care, obstacles and opportunities. And the content of this work was largely driven by some of the work I did during fellowship and more recently as a junior faculty member. I have no disclosures to report. So following today's presentation, I hope you're able to achieve a few objectives. The first is to understand the benefits and harms of antibiotic prescriptions in palliative care settings. The second is to identify factors associated with antibiotic prescribing in palliative care settings. And finally, to recognize strategies to promote goal concordant care of terminal infections. So what I'd like to do is start with a case that may highlight some of these challenges, many of which you might be familiar with during your own clinical experience. This patient was one of several that was described in a case series published in Open Forum Infectious Disease that highlighted some of the challenges in managing terminal infections in older adults with complex conditions. So this was a 72-year-old woman with metastatic non-small cell cancer. She had underwent lobectomy and palliative radiation therapy, and she was ultimately hospitalized at Yale New Haven Hospital with confusion and acute onset dyspnea. So at the time of our initial evaluation, she was febrile with a temperature of 103, tachycardic and hypoxic with a new oxygen requirement of 3 liters. She was in clear respiratory distress with diffuse wheezing noted on her physical examination. Additional evaluation was notable for bacteremia with Streptococcus galliticus that had intermediate susceptibility to penicillin, as well as a few notable imaging findings. The first was a chest CT, which showed a large 11 by 10 centimeter necrotic mass that invaded the chest wall with diffuse pulmonary emboli. Due to concerns for a complicated endovascular infection as well as endocarditis, a transthoracic echocardiogram was attempted, but the results were of poor quality. So the ID consult service at this time was tasked with the optimal management of this patient who, again, had advanced cancer and was receiving palliative radiation therapy. So she was ultimately started on ceftriaxone, and her bacteremia rapidly cleared after 3 days of therapy. During this time, there were repeated family meetings with the patient and her loved ones, and the decision was ultimately made that she would pursue hospice care. And by that point in her clinical course, she had completed 2 weeks of a planned 6 weeks course of antibiotics. And as the ID consultant, we were faced with a few challenging questions. The first was, how should this patient's infection be managed? Meaning, would she be a candidate for continued outpatient parenteral antibiotic therapy in the hospice care setting? Should she be transitioned to oral antibiotics? Are antibiotics consistent with hospice care and a focus on comfort? And so the optimal choice was not readily apparent. And then from my own standpoint and interest, it begged the question, should we practice antibiotic stewardship during end-of-life care? And this is just one example of many from the inpatient setting where this issue emerged. And I'll just highlight that, as you're likely familiar, antibiotic stewardship, focuses on the optimal selection, dose, and duration of therapy that results in the best clinical outcome. And from an ID standpoint, of course, we're concerned about minimal toxicity and minimal emergence of antibiotic resistance, but the appropriate clinical outcome is not always readily apparent during end-of-life care. And given the focus on comfort, the appropriate clinical outcome, often varies than traditional approaches. So I'd like to kind of move from that case, which should offer context for the rest of this presentation, and share just a brief outline of the presentation this afternoon. The first section will talk about some background information, particularly the scope of the problem, some rationales among prescribers, some of the work that we've done from our own research group in terms of adverse drug events in the palliative care setting, as well as national surveys of stewardship programs, and then just a brief summary. So, as you know, older adults with advanced illness face many challenging decisions. At the time of receiving palliative care, there are many questions regarding the overall direction of care and whether treatment decisions are in line with their own patient preferences. This is particularly relevant to complications that might emerge either from treatment for advanced illness or other unexpected outcomes. Unfortunately, infections and febrile episodes are one of the most common complications encountered by older adults with advanced illnesses. A variety of studies, both in the United States and Europe, have demonstrated that roughly 1/3 of patients with advanced disease, in this case, solid tumors, experience infections and febrile episodes. This includes patients both in inpatient and outpatient hospice and palliative care settings. So the literature on stewardship during end-of-life care has largely focused on 2 key populations. The first are those with advanced cancer, and the next are those with advanced dementia. I'll begin with just describing some of the data around antibiotic use and infections in those with advanced cancer. So according to the National Cancer Institute, nearly 10 million older adults, in this case defined as age 65 years and above, have cancer. Now, older adults account for the majority of cancer cases in the United States, and many go on to develop advanced cancer. Now, according to the National Cancer Institute, advanced cancer is an indication for palliative care. Now, it's perhaps unsurprising that this population incurs very high risks of infection, both due to host and treatment-associated factors. For example, patients with solid tumor malignancies may be predisposed to mechanical obstruction and polymicrobial bacteremia, and those with other malignancies, perhaps multiple myeloma and others, might be predisposed to infection with encapsulated bacteremia in the setting of hypogammaglobulinemia. So for a variety of reasons, these patients are high risk for infection. And unsurprisingly, many studies, including some of our own, have shown that 50 to 70% develop infection near the end of life. Now, the end of life period in this case refers to the last few months to weeks of life. Now, during this period, exposure to antibiotics is quite common. And what's fairly remarkable is that, again, both here and abroad, we see that many patients, including many patients who are transitioned to hospice, remain on antibiotics up through the last week and days of life. And so shown here, we can see some studies that are done out of portions of the US where it shows that 1/3 of patients following transition to comfort care remain on antibiotics. And then another study internationally showed that 2/3 of patients remain on antibiotics until the day of death. Now, these questions raise, these findings kind of raise questions about the goals of antibiotic therapy under these circumstances, particularly in the last days of life. What's intriguing as well is that when we account for patient preferences and outcomes that are important to patients, often they focus on relief of symptoms. And so this was an interesting study of patients with advanced cancer that was conducted, almost 20 years ago, that looked at the preferences of patients who entered hospice care with respect to the management of, infections or febrile episodes that might occur. And so you'll see here that among patients, when they were asked about whether they would prefer the use of antibiotics, the vast majority, you can see, roughly 80% preferred antibiotics for symptomatic use or no antimicrobials at all. Now, in fact, what happened following their care in this hospice facility, the vast majority, ultimately received antibiotics, and very few received no antimicrobials at all. So, reviewing this, one should wonder whether antibiotics really achieved these patient preferences, which was for symptomatic use for potential febrile or infectious episodes. Now, in addition to patients with advanced cancer, this literature has also included patients with advanced dementia. So in the United States, nearly 6 million older adults have dementia, and this population is rapidly growing and expected to reach 13 million over the next 2 decades. Comfort is a goal of care in many with advanced dementia who are immobile, have incontinence, are completely dependent with activities of daily living. And many high quality studies performed by a few investigators, Susan Mitchell in particular, have demonstrated that recurrent infections are the hallmarks of advanced dementia. And this was demonstrated in prospective observational studies where 2/3 of nursing home residents with advanced dementia had a suspected infection, most commonly pneumonia or urinary tract infection in a given year. And many of these infections actually occurred during the terminal stages of advanced dementia near the time of death. A half were diagnosed with pneumonia in the last 2 weeks of life. So again, unsurprisingly, antimicrobial use was found to be extensive in this population. And again, in these cohort studies, up to 2/3 received antibiotics in a given year. Again, these were nursing home residents with dementia, and many of these antibiotics occurred during the last 2 weeks of life. So I assume with this audience with the background in infectious disease, it should not be surprising that there is very strong evidence of harm associated with antibiotic therapy. Now, of course, we know that antibiotics will lead to, regardless of whether they're appropriate or not, will lead to antibiotic resistance, which, according to the World Health Organization, is one of the greatest health threats of the 21st century. And we also know that infections with multi-drug resistant organisms are associated with high morbidity and mortality. And according to recent estimates from the CDC, there are approximately 3 million infections associated with multi-drug resistant organisms and 36,000 associated deaths. Of course, another complex or poor outcome related to antibiotic therapy, particularly in the palliative care setting, is Clostridioides difficile infection, or the most common healthcare associated infections. But notably, these factors, these adverse events, these harms do not account for what could be more common adverse events, including drug interactions. Again, these are older adults with advanced cancer, advanced dementia. Polypharmacy is common. Drug interactions are what might be expected in other organ damage. Now, this strong evidence of harm should be weighed against the weak evidence of benefit of antibiotic use, particularly during end-of-life care. Now, there have been no randomized control trials to evaluate either the effectiveness of antibiotics for specific clinical syndromes during the end-of-life period. And importantly, outcomes of these randomized control trials haven't been done, and we haven't established that there's a survival benefit, and it hasn't been established that antibiotics are associated with relief of symptoms, which appears to be a primary goal for many patients at this stage of their illness. Now, one systematic review was done by a group in the Northwest, published in the Journal of Palliative Medicine, and this was a systematic review to evaluate whether antibiotics are associated with relief of symptoms for the most common clinical syndromes, and this would include urinary tract infection, respiratory tract infections, particularly pneumonia. And ultimately, the conclusion was that the data are conflicting regarding response to symptoms after exposure to antibiotics. And what is most notable is that in a prospective study, this was published in Archives of Internal Medicine, a prospective study of nursing home residents with dementia who were followed and developed pneumonia. These patients were actually given or offered a standardized scale of comfort that was completed following receipt of antibiotic therapy versus no exposure to antibiotic therapy based on the discretion of the provider and the residents. And in this study of 323 residents, antibiotics pneumonia was actually associated with reduced comfort as compared to treatment strategies that do not involve antibiotics. So based on these factors, we have published an approach to the management of infection during end-of-life settings. This was a paper published by myself and my mentor, Dr. Jutani, that strive to align treatment of infection with patient goals of care. And so in this figure, you can see on the x-axis, we have stages of disease where here we have early disease, advanced disease, and then to the dying process. On the y-axis, you'll see that there are two areas, one which is a focus on infection management and the other with goals of care. And so early on, during the early stages of disease, where goals of care for the patients and caregivers focused on cure, clearly diagnostic testing, including invasive diagnostic testing and antimicrobial therapy, are indicated. However, as goals of care transition to comfort and palliative care is offered, we propose that antimicrobial therapy be considered only if there was a non-futile survival benefit, if there's a transitional period between cure and comfort, or antimicrobial therapy being offered only in conditions where there's clear or strong evidence for symptomatic relief. Now, we would argue that these might involve perhaps Clostridioides difficile infection or other maybe topical antibiotics for necrotic infections, but largely antimicrobial therapy should be limited. Now, when palliative care transitions to hospice care and and disease advances, we propose that further diagnostic testing and antimicrobial therapy be deferred. So, with that being said, let's look at why some of these antibiotics are prescribed so frequently during the end of life. One of the most I thought interesting articles was a survey of pediatric and adult physicians from the University of Pennsylvania about 4 years ago. Again, this was a survey of adult and pediatric physicians. What I'm sharing here are key findings from the survey from adult physicians, and these were from all specialties. And so these were some reasons for continuing antibiotics during end of life care. So providers, 68% of providers actually believe that infection can be cured. 86% wanted to alleviate pain from infection, and this includes perhaps work of breathing. 59% continued antibiotics because the burden of treatment with respect to the route of administration or the frequency of administration is not excessive. And then notably, 86% of patients wish to respect a patient's request for antibiotics. And a large fraction also wish to respect a family member's request for antibiotics. Now, this is intriguing to me because often patients with cancer in the oncology setting, patients are deemed to be poor candidates for chemotherapy or not candidates for chemotherapy. In contrast, it's very rarely that we hear a patient is not a candidate for antibiotic therapy or otherwise a poor candidate. So this is quite notable. And granted, there are some aspirational reasons for wanting to continue antibiotics, but I would argue the evidence supporting relief of symptoms is quite weak. Now, what were some of the reasons for discontinuing antibiotics? Only 2/3 thought that resistance could be reduced. Almost 90% were concerned about side effects beyond just resistance or C. diff. Again, these would include drug interactions, end organ damage, other issues. 3/4 were concerned about Clostridioides difficile infection. And notably, 98% would respect a patient's request, and this was a request to discontinue antibiotics. So if the patient preferred to avoid antibiotics, that would be acknowledged, and this was in the inpatient setting. So that is quite notable to me, at least. And these were some illustrative quotes from this survey. So some providers, these were some of the common themes. So providers wanted to avoid the perception of giving up or not doing everything possible. So a specific quote was, "We usually err on the side of giving antibiotics to not be the final hatchet man." There's also uncertainty about prognosis. Of course, as physicians, we can't predict the future all that well, and the end of life period is clearly poorly defined. And here, one provider mentioned the end of life is often nebulous, not so clear cut decision and timing wise. And finally, one theme was to reduce pain and suffering. I would only consider continuing antibiotics if they are palliative and relieving physical pain. I would again, like to see, the strong evidence is supporting that separate from other modalities that could also reduce physical pain separate from antibiotic therapy. So what is the kind of current body of knowledge in this area? So last year, a systematic review and meta-analysis was published in the official journal of the Society of Healthcare Epidemiology that looked at antibiotic use during end-of-life care. This review included 72 studies. A good proportion were from the two key populations I mentioned, advanced cancer, advanced dementia, and then some half involved mixed populations of these groups. And overall, across all 72 studies, 2/3 reported antibiotic use in over half of patients during end-of-life care. And what's interesting is that in the subset of studies where they can compare antibiotic use with and without palliative care consultation, it was found that antibiotics were more likely to be offered during palliative care consultation versus non-palliative care consultation. So the extent of this problem has been recognized by IDSA and SHEA, and these are actually addressed in the IDSA guidelines for implementing an antibiotic stewardship program. And this is kind of what's mentioned in the guidelines. Should antimicrobial stewardship programs implement interventions to reduce antibiotic therapy in terminally ill patients? And the recommendation here is that in terminally ill patients, stewardship programs should provide support to clinical care providers. Now, that's a very general statement, and more specific guidance or potential interventions are lacking. And so that's where we stand. And what I'd like to do now is transition to some of our own work that's looked at this issue. So what's intriguing to me in this domain is that perhaps if it's difficult to establish relief of symptoms associated with antibiotics, perhaps instead we can establish the harms of antibiotics, which might inform patients, caregivers, and providers, particularly during goals of care discussions. And so that was the rationale that motivated this work that sought to evaluate adverse drug events associated with antibiotic therapy during palliative care. So prior studies, particularly, this was a highly cited study from JAMA Internal Medicine, has demonstrated that adverse drug events occur in nearly 20% of inpatients that are exposed to antibiotics. Now, in this study, there was very limited representation from older adults, and it was unclear whether anyone actually received palliative care or had terminal illness. And our hypothesis was that adverse drug events would be far more common in this population. And so we conducted a cohort study to evaluate the association between antibiotic therapy and adverse drug events. And our inclusion criteria were age greater than 65 years and the receipt of palliative chemotherapy during a defined time window. Now, palliative chemotherapy in this case was defined as non-curative therapy, which was not intended for survival, but again, palliative in nature. And we followed all patients through their index hospitalization following receipt of palliative chemotherapy, with the thought that hospitalization could be a sentinel event and might be an opportunity to engage patients in goals of care discussions regarding their trajectory in the use of antibiotics. And we excluded patients with hematologic malignancies due to the frequent role of prophylaxis and also expected adverse drug events related to their chemotherapy. So our independent variable was antibiotic therapy as measured as days of therapy. And our outcome was the development of adverse drug events. Now, these were the same adverse drug events that were used in prior studies, including the one mentioned previously in JAMA Internal Medicine that looked at the development of cardiotoxicity as defined here, nephrotoxicity, hepatotoxicity, as well as those that might be more pertinent to ID providers, which was Clostridioides difficile infection and multi-drug resistant organisms. So overall, during the study period, we identified over 2,500 older adults who received palliative chemotherapy. Now, many of these were excluded because they were never hospitalized, at least within the Yale New Haven health network, which includes many hospitals in the region, and a small subset had hematologic malignancy. Now, of the remaining patients, of the remaining approximately 900 that were hospitalized, what is shown here is the distribution of patients who were exposed and unexposed to antibiotics. So we can see here, among those that were hospitalized for any reason, a good fraction, almost 1/3, did not receive a single antibiotic during hospitalization. And nevertheless, 18% of these patients developed at least one adverse drug event during the follow-up period, which was the duration of hospitalization, or 90 days for C. difficile and MDRO. So at baseline, there's already a high probability of developing an adverse drug event. Now, once antibiotics are introduced for any reason, the probability of developing an adverse drug event increases almost twofold. You can see here 34% where it's less than 1 day of therapy, or up to 35% if it was greater than 1 day of therapy. Now, in a multivariable regression model, we basically evaluate whether antibiotic therapy was independently associated with the development of an adverse drug event, even after accounting for patient comorbidities, hospitalization characteristics, and so forth. And here is shown a few factors, the factors associated with the development of adverse drug events. Not unexpectedly, exposure to antibiotic therapy was independently associated with the development of adverse drug events. And perhaps it might be intuitive, polypharmacy, as defined by having more than 10 medications, this was excluding PRN medications, more than 10 medications at baseline, was associated with the development of adverse drug events. ICU admission, not unexpectedly, as well as liver disease. So overall, we hope to show that over 1/3 of older adults with advanced cancer develop an adverse drug event associated with antibiotics during hospitalization. And this was, again, the index hospitalization after receiving palliative chemotherapy with a potential opportunity to discuss goals of care. And we argue that the high potential for harm associated with antibiotic therapy in this population should be weighed against really the perceived benefit of antibiotic therapy in palliative care. And so the next thing I'd like to share is a national survey of antibiotic stewardship programs. So I've shared guidelines from IDSA that make a recommendation that stewardship programs should provide guidance to providers regarding antimicrobial therapy during end of life. But again, more specific recommendations were lacking, and there were no concrete examples of potential interventions. And so the purpose of this survey was to understand what stewardship programs were doing around the country during the management of these patients. So this was a survey of hospitals participating in the SHEA research network. This is a consortium of roughly 100 hospitals across the country, some also internationally, that are engaged in research related to hospital epidemiology and stewardship. And what was shared with these hospitals was a case vignette and subsequent questions related to this case vignette. Because the end of life period is very nebulous and not well defined, we defined end of life care as care being offered to patients engaged in active goals of care discussion, through which there's been agreement for no escalation of care. But comfort measures have not yet been implemented. The rationale here is that many hospitals may have protocols that following transition to comfort measures, maybe all medications outside of a few will be discontinued, particularly antibiotics. And The case we just provided was an older woman who was receiving palliative chemotherapy and experiencing recurrent fevers in the intensive care unit. And recovery was deemed to be rare, and there's been multiple goals of care discussions. Based on review, this was from a stewardship perspective. It was thought that the patient would be unlikely to survive for more than 1 month after discharge, and providers and family members are engaged in how to proceed. But comfort cares has not yet been offered. And so providing this case vignette, we again asked stewardship programs how they might manage the situation. So of the roughly 100 hospitals that were available in this survey, 36 responded, so a response rate of 38%. And there was a distribution of hospitals. Many were academic centers. A fourth were from large hospitals over 900 beds. And from these hospitals, the majority had at least one physician, one with one FTE dedicated to antibiotic stewardship. So some of the key findings are that in these hospitals, the vast majority, 92%, had a dedicated palliative care service. However, only 2/3 were engaged in any collaboration with palliative care providers with respect to educational, joint collaborations in terms of patient management, or perhaps palliative care consultation with stewardship programs. And so this was a notable finding, which I suspect would be generalizable to other institutions. The next is looking at whether approval of restricted antibiotics was affected by the patient code status. And here, not surprisingly, stewardship recommendations were more often provided for intravenous antibiotics provided at the end of life as opposed to oral. But what was notable was that there was a trend for the approval of restricted agents to increase or to change with the change in code status. So you can see that when patients are transitioned to comfort measures, they were more likely to approve restricted agents. Now, this was a bit unexpected. Perhaps the thought is that following transition to comfort measures, typical length of stay is on the order of 1 to 2 days, but this was notable. Now, we also asked stewardship programs, representatives from these programs, to provide free text responses for how stewardship programs could be involved during palliative care. And these were some of the common themes. Stewardship programs could play a role in discerning side effects. If antibiotic side effects don't support dignity and ease of suffering, then they need to be stopped regardless of route of administration. They could also support palliative care providers, and I think this might be the most interesting opportunity. Stewardship programs could support the recommendations of palliative care physicians during end-of-life discussions. And antimicrobials could be seen as similar to intubation or cardiac resuscitation as a death prolonging measure. Now, that's notable because in some states, antibiotics are kind of mentioned in different pathways for advanced care planning. Stewardship programs could also be involved in refining guidelines and education. So developing more formalized guidelines for helping providers with decision making, and finally, education. And I think this is another key piece, in particular on understanding how the end of life time period affects the risks and benefits of antibiotic use. And our prior study hopefully will highlight how the risks and potential harms of antibiotic therapy are quite high during this stage. So some of the implications here that collaborations between stewardship programs and palliative care services are lacking. This is a potential venue for ongoing work. Approval of antibiotics appeared to be influenced by patient goals of care. That's also worthy of further investigation. And there are some clear ways where stewardship programs can actually, actually provide um, some um, some benefit to clinical care of patients during end of life with receiving end of life care. So, just to summarize, what I hope I communicated was that the management of infection at this stage is a complex process where there are many different issues at play in terms of uh, managing the transition to futility, respecting patient wishes, as well as uh, the potential autonomy by physicians to prescribe as desired, but then also upholding best practices in palliative care, again, focusing on patient dignity, goals of care, and infectious disease with a desire to reduce adverse drug events, resistance, and C. difficile infection. We know that antibiotics are most common in these two populations, advanced cancer and advanced dementia, and there appears to be a role for antibiotic stewardship, particularly with respect to palliative care. And one thing that could be explored is advanced care planning and opportunities to revisit that. What we don't know is quite vast. There are no randomized control trials that have focused on survival or relief of symptoms associated with antibiotics, either overall or for clinical syndromes such as urinary tract infections or pneumonia. This, I imagine, would be a very difficult trial to perform. There are also no effective interventions on either reducing antibiotics or improving antibiotics that are most effective in reducing symptoms associated with infection. This is challenging because the end of life period is often nebulous, and defining the appropriate outcome for patients, for providers, and for caregivers is challenging. And guidelines, as I've highlighted, are lacking. And so with that, I'd like to revisit the case that I highlighted at the beginning of this presentation. If we recall, this was an elderly woman with advanced cancer who was hospitalized with a complicated endovascular infection with strep galliticus, and the decision was how to manage her antibiotic therapy. At that time, she was receiving ceftriaxone, and there was a planned course for 6 weeks. And so at this time, we recognize that continued intravenous therapy or daily, regardless of frequency of administration, at least at our institution, was incompatible with the receipt of home hospice care. However, the patient and the family both expressed a desire to continue treating this infection to prolong life. And so at that time, we thought the best course of action might be to use a long-acting agent, such as iridovancin, which is a long-acting lipoglycopeptide, which has a prolonged half-life and has efficacy against gram-positive bacteremia associated with invasive infections. Using an agent like iridovancin, a one-time administration, might offer goal concordant care. The patient and family were reassured that the infection was being managed. There was no associated discomfort of repeated intravenous injections, and it wasn't a barrier to receiving home hospice. And so this patient was ultimately discharged on home hospice after receiving a dose of iridovancin. She was also treated symptomatically and ultimately died in home hospice 2 weeks after receiving a dose of iridovancin. Now, understandably, iridovancin is a fairly expensive drug. There are other options, including dalavancin or other long-acting agents that could be considered. But this was just one case of a few that highlighted alternative approaches to the management of infection during end of life. And so with that, I'd like to thank the many folks involved, some of my mentors, Dr. Dembry, Dr. Jutani, who's now the Commissioner of Health here in Connecticut, many from the section of geriatrics who have been involved in this work from the Yale Cancer Center, and finally, many others who I collaborate now with on the topic of outpatient antibiotic use in patients with complex and disabling conditions, particularly in home-based primary care. And that work is funded by some of the agencies shown here. So with that, I'd like to thank you, and I'm happy to take any questions.
Thank you. That was actually so relevant to what we do around here. Is there any other questions? Any questions from anyone?
I've got a couple of questions. Thanks, Dr. Datta. That was fantastic talk. And appreciate all the data on the sort of adverse events as sort of arm us to sort of help with communication with other clinicians and family. But I get, the first question was, when you looked at the adverse events in your study population that was enriched with older adults, end of life care, did the specific adverse events differ from those prior studies that looked at sort of a more general hospitalized population?
So the adverse events, I think you're referring to this study, were defined similarly as the prior study published in JAMA Internal Medicine. So these are the common adverse events. The difference here was that at baseline, there was already a high risk independent of exposure to antibiotic therapy, and then adding antibiotics just increased that risk multifold.
As far as though, like the breakdown of which categories they fell into, was there more C. diff, you know, in your population versus what's previously been quoted, or more cardiac events?
Yeah, that's a good point. So that degree of detail, I can't recall for the prior work, although it's interesting that you mentioned that would be worthy of comparison. In this study, the most common side effects were nephrotoxicity, followed by the emergent, followed by these two. We grouped these together, and then cardiotoxicity.
Thanks. And then one other question. This is sort of more general, and I'm not trying to phrase this, but I liked how you looked at communication between infectious or antimicrobial stewardship and palliative care. But from my experience, when it comes to sort of end-of-life decision-making, particularly in that population, the oncologist is really the one person who the patients and the family trust the most, right? And you know, not to lay judgment, but a lot of times they're not around when the patient's hospitalized and sort of in a worse condition than sort of the previous prognosis given. And from my experience, palliative care is great, ID is great, but whatever we say really gets trumped by whatever the oncologist says. So any thoughts on how to study that sort of level of communication that involves the oncologist as well? And sort of feel like they're the person who can really make a difference. And so, yeah, I guess that's sort of my general question or comment, or just wondering to hear your thoughts on that.
Yeah, no, thank you so much, Dr. Mills, for bringing that up. I mean, your experience is consistent with my own, and I assume would be common elsewhere. You know, in thinking about this issue, our thought was that when patients are started on palliative chemotherapy, there's a clear consent form, at least in our electronic medical record. There's a discussion that is had. There's clear expectations on what palliative chemotherapy is intended to achieve. Our thought was that during this time, that's a key event where perhaps that could trigger some sort of multidisciplinary discussion about expected trajectory, expected complications. Maybe at that time, there's a role following that decision from the oncologist to engage with palliative care providers who might be armed with information from infectious disease physicians. Now, all that being said, how likely is that to impact outcomes? I agree. Ultimately, the oncology and their recommendations carry significant weight, and during hospitalizations, priorities change quickly. That was our thought process, at least in terms of the workflow at our institution. But I agree with you; it's a very difficult situation.
Yeah, it sort of sounds like you're going beyond just the question of antibiotics at that point. What you're really sort of talking about, and what I agree with you is really important, is this whole question of what does palliative mean and what are the expectations for the patient. And we know, one of our private oncologists here has given a really wonderful talk about end of life issues for the entire medical staff. And he talks about how when he first sits down with the patient, he talks to them about, you know, sort of bigger and smaller picture and shorter and medium and longer range goals, even before they get to the, you know, the palliative part of the treatment, you know, even when it's just a newly diagnosed cancer. But not everybody does that. And there's that whole thing about hope, you know, that a lot of people still have that concept that if you really sort of lay it out that way, or you bring this up, you're getting rid of hope. And so that sort of goes beyond what we're talking about here, even in terms of antibiotics. We're just a small part of that piece.
Yeah, I thank you for sharing that, Dr. Barkov. I agree. I mean, it's a very difficult situation. And this also brings to mind one of a presentation from Dr. Brad Spellberg at the SHEA conference just recently, in terms of, you know, who can prescribe antibiotics. I mean, ultimately, you know, all providers can, you know, prescribe freely, often, including oncologists and others. But very few are not able to prescribe. And so it just, I think we should, all this raises questions on, you know, what is the approach to managing and prescribing antibiotics during end-of-life care and goals of care. I agree.
Does anybody else have comments or questions?
Hi, Dr. Datta. That was a great talk. You mentioned something, and I might have missed it, about how it would be good for collaboration between palliative care and stewardship to come up with decisions. Would that be via, do you have like a protocol or something, or it's just like a one-on-one? Is that something that you do there? And is that like a one-on-one type of consultation, or is there some type of protocol that you go through?
So this is, as far as we know, uncharted territory. So what we're doing here, and please excuse the background noise, what we're doing here is, at least with the Palliative Care Fellowship Program and some at the Yale Cancer Center, there's an interest in developing a communication guide in terms of how do we think about antibiotics and what sort of language can be used to communicate the importance or the significance of infection versus antibiotic therapy. So that's kind of something that's in the works in terms of a communication guide. The rest is largely you know, education in terms of, you know, work like this, expected side effects and benefits. But I think as a start, communication might be good, just given some of the data from the meta-analysis and elsewhere. I hope that answered your question.
Yeah, I was just thinking about how to broach this, because we have palliative care now for a couple of years and we haven't really approached them about stewardship, unless I'm rounding and there's a certain case and then it becomes a case-by-case basis. But listening to your talk made me think that is some area that we do need to tackle, because we do see a lot of antibiotics being used, especially in end of life. And the study that you mentioned was looking at so when that's you have on the screen, non-hematologic malignancy patients too, right? Is that just because it's harder to get the heme malignancy patients to stop antibiotics, like the physicians taking care of them to stop antibiotics?
Yes, certainly. You can kind of read between the lines, and the role of prophylaxis and neutropenic fever and other complications. Yeah, that was some of the rationale. And at least at our institution, there could be a pathway for developing a relationship with oncologists as compared to, you know, other specialists in that domain. You know, the other thing, you know, I'll mention is that, you know, this work focuses on hospitalized patients. I think there's, you know, there's a role also for, you know, palliative care that's delivered in the outpatient setting as well. This was just work on hospitalized patients, thinking that that wasn't a time where we could intervene, but I'm sure there are other opportunities as well, given the frequency of pneumonia versus aspiration, atelectasis, and other things that might represent infection.
Okay. Any other questions or comments? That was really great. Thank you so much.
Thank you so much for the opportunity. I really appreciate it.